On budget, almost on time, so appreciate that. Our next speaker is going to take, I think it's safe to say, a somewhat different perspective for a couple of reasons. Both politically, he's on a different part of the spectrum, but Dr. Bob Berenson is also unique amongst this group, a physician who has actually practiced medicine for 20 years. In addition to that, he has held a number of high-ranking positions in the government. He was the director of Medicare payment policy in the Clinton administration, and he recently completed a 3-year term on Medicare Payment Advisory Commission, the last 2 years of that as vice chairman, and he's a highly regarded expert in healthcare policy, particularly Medicare, and we welcome him for his views here. Thanks. Bob.
It's a pleasure to be here. I also want to thank Paul and Margaret for inviting me back. I was here in 2007. Enjoyed myself then, and I'm happy to be back here to talk about Medicare. As opposed to the broader issues in the ACA, a lot of the budget issues associated with the ACA are about Medicare. Now, when Margaret invited me, I don't know if this got communicated, but the sense was we wanted a couple of Republican-leaning members of the panel and a couple of Democratic-leaning members of the panel. Kavita couldn't be here today, so I'm the Democratic-leaning member of the panel. But in fact, having just heard Joe's presentation, I don't think our disagreements, of which there are some, are so much on a political spectrum, because actually what Joe said was pretty reasonable. So the chances... we will have some differences, and I will point out where we don't disagree and in some places where we probably do. The way I have framed my discussion in calling this Addressing Long-Term Debt, Medicare Restructuring, or Continued Evolution is essentially to take on not necessarily Republicans who have political motivations, et cetera, but sort of those people who I respect, who are opinion leaders, I guess, the people like David Brooks in the New York Times or Morning Joe, and some of the people on Morning Joe, who are convinced and just sort of say it as rote that if anybody is serious about getting Medicare spending under control, and we all agree that it is a major driver of long-term debt going forward, if anybody is serious, they need to restructure the program. That there's no way that Medicare can be sort of contained or put on a good path for sustainability for itself, as well as not be a major driver of budget deficits, unless we do some major overhaul. That's what I'm challenging. I think that's just a completely wrong frame for the program. And I'm going to try to explain why that is. So if I have this right, I do. So first, I want to clarify the reasons for Medicare's expected huge impact on the budget. And I would argue, and Joe actually sort of acknowledged this himself in his presentation, it's largely demographic, at least over the next 25 years or so, in the first year of the baby boom generation. George Bush is 3 weeks older than me. Bill Clinton is 2 weeks younger than me. We are the wave. And there's 25 more years or something. I don't know how wide the baby boom thing is. I think it's 25 years or 30 years worth of us coming through. Whereas Medicare population growth into this century had been on the order of under 1% a year. In the last few years, it's been going up to 2.5%, and I think the general projections are about 3% a year. So that, yes, over the next 25 years, this is from CBO estimates from a little while ago, that about 50% of the increase of Medicare spending would be from the population served from less than 50 million now to about 80 million by 2030. It's population growth. The beneficiary growth was projected to be about 3% or about half. Now that I mean, Joe pointed out that it has generally been and still higher than the growth of the economy. But it's certainly lower than it has been in the history of the program. It is lower than growth of private sector health spending, of premiums for health insurance. People do have different numbers on this one. Joe had 2 years. I thought I heard Jim talk about 3 years' worth of data, not exactly the same numbers I have. That is one thing. One does like to cherry pick the most favorable numbers. This comes from HHS. Their assessment of the 3-year per capita growth in Medicare from 2010 through now 2012 is 1.9%. Nobody thought it would be like this, and there is, in fact, real reduction in the growth of volume and intensity of services. Why that should be has been something of a question. That same reduction in volume of services has clearly been seen in private insurance, and a lot of people have attributed that to the recession and the fact that people have less discretionary money. In fact, the slowdown in growth began before the recession began. It may be partly associated with high deductible plans, as John talked about earlier. But it's also being seen in Medicare, where 90% of beneficiaries have supplemental insurance, mostly first dollar supplemental insurance. And the question is, why would we be seeing this slowdown in volume and intensity of services even in the Medicare program? I don't think we know that. I think we need to try to find out. And I agree with Joe. We do not know if this is just a short-term sort of change. I've seen some curves that associate growth in costs and specifically in volume of services with what's going on in terms of national health reform. Whenever there's a big push for some big national program that's going to come and regulate prices or hospital cost containment in the Carter administration or whatever, whenever there's a major focus, there tends to be some moderation in cost growth. And then when the pressure is off, it goes back up. That's possible. But I actually think, as I'm going to talk about in a little more detail, some of this might well be sustainable. But what I want to do is take on a couple of enduring Medicare myths, which I think feed this notion that Medicare is out of control, therefore needs major restructuring. As I tried to suggest, I don't think it's out of control. If by out of control implies sort of a bloated, inefficient program, in a few slides from now, I'm going to talk about some areas of real problems in the program which need attention. But as an overall matter, the program's not out of control. I don't think the case is there that it needs major restructuring. And certainly the approach to restructuring that David Brooks endorses, and serious people, if you're serious about Medicare costs, you would endorse this, would be that the way we do this is through market competition as the primary solution. I'm sure you all followed the sort of tale of Paul Ryan's premium support. It was initially going to be competition only amongst private health insurers, then for political reasons probably. Traditional Medicare became one of the competing plans. Even that was quickly labeled by Democrats as a voucher, and during the Romney-Ryan campaign, it sort of disappeared as a topic. It wasn't viewed as a sort of political winner. So there were political reasons for why it has faded at this point. But I would use a different reason. We are doing competition in Medicare right now. We have 27% of beneficiaries. Actually, I have that in the next slide. 27% of Medicare beneficiaries currently have the choice and do opt into a Medicare Advantage plan. And people expected that this number would immediately start dropping as the Affordable Care Act reductions in payments started hitting. They actually had only hit modestly. Next year, they're really going to start hitting actual reductions in the benchmarks against which the plans bid. But still, enrollment has been going up. The analyses that compare how much it costs Medicare Advantage plans to provide Part A and Part B services for the population compared to this inefficient, bloated traditional Medicare program shows that only in about 15 to 25% of the country are the plans less expensive, cost less than the traditional Medicare program. And that tends to be, I mean, the classic case is Miami-Dade. If you want to look at a place where Medicare, traditional Medicare, has a problem of bloat, it is in Miami-Dade. But on a national scale, Medicare Advantage plans aren't less costly. So the question is, but they haven't really been in a competitive system. I would say they have been in a competitive system. They bid against the benchmark. If they bid low, they get more market share. There are some reasons to believe that perhaps if you had a somewhat different bidding mechanism that has been advocated in premium support, not bidding against a known benchmark, not having, in essence, a tax on the bid where Medicare keeps 25%, maybe the bidding dynamics would be somewhat different. But I've talked to CEOs and CFOs of Medicare Advantage plans who basically tell me, yeah, we're doing competitive bidding right now. It hasn't resulted in savings. Now, in a few slides, I'm going to say we'll have a real test because the payments are going to come down, and the plans that will do well will have to become leaner in their operations. But so far, there is no reason to think that premium support would do anything but shift costs onto beneficiaries. That would be the major effect of premium support. That's not sort of a positive restructuring of the program. That's just deflecting who's paying the bill. So going back to the third myth that I've identified, traditional Medicare, and I never call it, or I rarely call it fee-for-service Medicare, which is the inside the beltway shorthand for this program. It isn't fee-for-service, as I will detail. The basic myth is that it is mired in antiquated insurance benefits and payment models. The former may be true in terms of a benefit structure that hasn't changed since 1965 and needs to be updated and somewhat overhauled. But the payment models are not mired in 1965, which is where I'm going to go right now. So the Washington Post, January 6, 2013. The program's design, often tweaked but left fundamentally intact since its creation in 1965, basically pays doctors and hospitals fixed fees for whatever they do. In fact, you all know, those of you who work in hospitals, those of you who work for health plans, know that Medicare hasn't paid hospitals for whatever they do since 1984, since DRGs became the payment model. It pays case rates that many other U.S. payers have adopted. By my last count, at least 14 countries pay hospitals now on diagnosis-related groups. It's paid for an episode of care. Hospitals have an incentive to not do unnecessary services. It can be improved. My point is that that's an evolution, but it isn't a fee-for-service program. The Medicare fee schedule, the way doctors are paid, are the leading example, the exception to my point. But home health is now paid on an episode payment. We're bundling payments for end-stage renal disease. It's, in fact, not as portrayed. The Wall Street Journal, every couple of years, sort of trots out the line about Medicare relies on Soviet-style bureaucracies and Soviet-style price controls. Clearly, Medicare largely pays, traditional Medicare largely pays administered prices, not market-determined prices. So that I acknowledge, although that's somewhat changing. But in fact, commercial insurers use the same administered prices, they just pay more. It's pretty well documented that commercial plans pay physicians about 20% more than traditional Medicare, not for their Medicare Advantage business, but for their commercial business, and they pay hospitals about 30% more on average. In some markets, doctors and hospitals get substantially more than that because of consolidation and acquisition of market power. But it's not like private plans have figured out some much better payment model than what traditional Medicare uses. And the competitive bidding approach for durable medical equipment seems to be pretty successful in Medicare. Needs to be expanded throughout durable medical equipment, but probably for some other services that are commodity-like, to actually use market prices rather than just administered prices. So now let's go to what can be done in Medicare, because regardless of whether the major problem is from population growth or the pressure is from population growth, I believe there's plenty of opportunity to continue to reduce per capita spending because there are some inefficiencies in the program. I don't think it's a program out of control, but I think there are opportunities. So, so I want to distinguish between long-term and short-term cost control strategies. Long-term, in my view, is at least 8 to 10 years. I mean, there are some people, generally on the Democratic side, interestingly, who basically say we need to move immediately and adopt whatever seems to be available, bundled episodes, premature adoption of ACOs, whatever it might be, because we've got this problem. I think, in fact, the results of the payment reductions from the Affordable Care Act to hospitals and some other, and health plans and to some other providers, as well as some other things that are happening to restrain volume, actually provide some breathing room that will be necessary to figure out if any of these new payment models are going to work or not. I think there's a lot of rosy scenarios around some of these payment models, but we have the time to do it. I think, as I suggested earlier, in a period of relative restraint of per capita spending growth, and now that there is going to be pressure on Medicare Advantage rates to be more in line with traditional Medicare, the plans can now, they have the time to demonstrate that they can provide higher value. As I'm going to go through, they should be able to actually be lower cost than traditional Medicare. They haven't up till now. We'll see what happens there. And I do think we can reform the benefit package to decrease the need for supplemental insurance and to make more value, to make it a higher value. I'll come back to that briefly later. In the meantime, I think there are short-term opportunities. Evolving the current payment approaches even more and continuing to get prices closer to right. I agree that you can never get administered prices exactly right, but you can sure do a lot better than we have been doing in some areas. Going after aberrant, often fraudulent behavior, and then I'm going to spend a moment just talking about one area that would be new if Congress allowed CMS to do it, which is how Medicare covers services, new technology or extended uses of established technology. There's a lot of those services that are covered and paid for that don't provide added value to beneficiaries, but basically CMS is unable to do anything about that. So let me now give you some, some examples of where I think continued evolution of what's already working can keep this program under some spending control. MedPAC finds that market power permits hospitals to reap higher revenues from non-Medicare payers, so of higher cost structures and negative Medicare margins. What this is all about is there is a sort of notion that some have promoted that there is a cost-shifting hydraulic. If Medicare reduces its fees, the fees go up the same amount to private payers. And I said earlier that private payers pay more for hospital care than Medicare does. It's not that clean cut. People who have looked suggest there is some cost shifting going on, But probably what's more primary is that hospitals with market power just get higher prices from health plans regardless of what Medicare is doing. The MedPAC analysis suggests that they found about 1,000 hospitals out of about 5,000 hospitals that actually are in less advantageous position to get high prices from private plans, have positive or at least neutral Medicare margins, and have high quality. In fact, this would argue that the sort of looking to hospitals to not provide generous payment updates, whether you call it a productivity enhancement as was done in the Affordable Care Act or something else, one can continue to put some pressure on hospital payment rates. I think private plans have a problem of market power from hospitals who are consolidating. California is sort of the home of Sutter Health, which has 27 hospitals, is now, well, you can't acquire physician practices in California because of corporate practice of medicine, but you can certainly affiliate with a foundation and raise prices for the hospital and for the medical group, and that is a problem. That's not Medicare's problem. I think we're going to have to deal with that one regardless of what we do with Medicare. The SGR mess has obscured some basic problems with the Medicare fee schedule. Price distortions have led to costly physician behavior. Too much testing, not enough interaction with patients and other clinicians and providers to coordinate care has contributed to the current lack of interest in primary care. The one place I would disagree with Joe, I don't think you had time to talk about it. Joe had a line on there that said that fee reductions don't change incentives. I actually think fee reduction do change incentives, and they can change incentives in either direction. So I point to what the Congress did in the Deficit Reduction Act of 2005. It was a time in which every year, actually, the Congress has to find the offset for the doc fix. When they want to make the SGR go away for another year, they have to pay for it. Well, in 2005, for reasons I don't understand, at that time we were paying imaging centers in the physician fee schedule more than we were paying outpatient departments for the same services. An MRI of the brain, very common imaging services. Generally, it goes the other direction. We actually pay hospitals a lot more, and that's a reason that hospitals are buying up cardiology practices. But here it was going in the other direction. Congress basically said, we're not going to pay physician practices any more than we're paying outpatient departments. That resulted in a major reduction in fees. The net was about a 12% reduction year over year in what was paid on the price side. So what is sort of the knee-jerk reaction there's this view that has been incorporated into estimates of the physician fee schedule that if you reduce prices, docs just do more services to at least partly offset those price reductions. Well, that's not what happened. What happened was that the rate of increase in those imaging services came down. What I heard anecdotally was that every mom-and-pop cardiology practice or oncology practice that was just buying up MRI machines or PET scans or whatever it might be as an ancillary service enhancement, they said, this isn't a profitable service anymore. We're not buying those machines anymore. And in fact, you can affect volume by affecting price. So I think we could be a lot smarter with how we set prices in the Medicare fee schedule. It is possible, some services you probably would get that behavioral offset, but I think if you do it smart, you actually can reduce prices, reduce volume. So some egregious examples of what needs some attention. Durable medical equipment. Miami-Dade. They spend $2,200, this is 2006, $2,200 per capita just on durable medical equipment. I mean, it's 5 times more than Broward County, which is right next door. Another example. I think most of you read Atul Gawande's article about McAllen, Texas, which as I understand it, the president read and called everybody in and wanted to talk about what we're going to do about this. Well, it's interesting. McAllen, Texas, he pointed to the problem of physician entrepreneurialism. had a small one paragraph on this problem, which is that in McAllen, Texas, home health services per capita are 7 times the national average. Home health services represent something like 6 to 8% of the total Medicare budget. Somebody who did the analysis for McAllen told me that the reason McAllen is so much more expensive, half of it was because of this home health phenomenon. We don't know much about why that's going on. Are there kickbacks going on to docs? Are they using this benefit because Texas might not be paying for home and community-based services and Medicaid? I don't know, but it sure doesn't smell right. In some counties, greater than 35% of beneficiaries use home health, and yet eligibility for home health services requires that the beneficiary be homebound and need skilled nursing. I don't believe 35% of beneficiaries anywhere would meet reasonable criteria for that. And then to me, the most egregious is this next one. Hospice patterns. I came in a little late this morning hearing about hospice. I picked I have 2 states in the national average. So the national average finds that about 40% of Medicare decedents die in a hospice, with a hospice benefit, and that they have 18% of them have lengths of stay of more than 180 days, although a doc is supposed to make a best estimate that a patient's prognosis is less than 180 days. That's not 100% reliable, and so yes, you tolerate some variations. In the state of Mississippi, 39% have stays greater than 180 days, and now catch this one, 55% of people in hospice are discharged alive from the hospice. I think I have some reasons why that happens. I mean, there is a per capita cap on how much hospices get paid, so a lot of people who shouldn't have been in hospice in the first place, who were not going to die, are then found they're no longer profitable because they've hit the cap and they're just discharged. We got a whole bunch of problems we could work on, is my point. And then this is the final one, and then I will finish. CMS is precluded from considering costs and coverage policies. I would argue CMS doesn't even have the ability, because of a lack of resources mostly, to administer its own policies that it is allowed to do. So implantable cardioverter defibrillators. It's a long term for the thing that Vice President Cheney had that shocks him back to life if he has ventricular tachycardia. It's a very useful thing that many patients benefit from and have longer life because of it. But a JAMA article found that 22.5% of them don't meet clinical guidelines. I haven't seen the analysis that compared the clinical guidelines used in the article with the coverage policy that Medicare established when it covers NCDs. But my suspicion is that more than 20% of Medicare beneficiaries getting NCDs don't meet the criteria for getting NCDs, evidence-based criteria, not taking into account costs or cost effectiveness, which is basically precluded by the Affordable Care Act, but simply effectiveness, simply the ability of CMS to administer its own policies. And my estimate was that one service might cost about $1 billion a year. There's some literature suggesting for a large number of other services, Medicare doesn't actually, that clinicians ignore basically the Medicare coverage policies. Now, we now have a new administrative entity called the Recovery Audit Contractors, who might have a financial incentive in sort of identifying this problem and going after that. We'll see. My point is there are lots of places, all of which raises the question of why Medicare Advantage plans aren't lower cost than traditional Medicare. I mean, those fraudulent things or those implied, MA plans presumably contract and know who they're working with. MA plans actually don't pay those commercial rates that I said were 20 or 30% higher than Medicare. They, for the most part, at least for hospitals, pay closer to Medicare rates. There's evident opportunities, especially with increasing numbers of patients with chronic conditions, to put in specific care management processes to reduce unnecessary hospitalizations. And there is some evidence that MA plans do that better than traditional Medicare does. And yet they don't save money. And obviously this one, and whether the remarkable reduction in per capita spending can be sustained. So to finish, there are plenty of proposals to reduce Medicare spending and raise revenues without major program restructuring. I would point you to this document that I was a co-author on by the Kaiser Family Foundation, published in January. They had more than 150 options on the revenue side, on the spending side. They all, virtually all of them, are not layups. They all have certainly political considerations. Many have substantive considerations. There is plenty of opportunity to come up with a package, if we had a political will or a political mechanism to do so, to sustain, in my view, Medicare spending for the long term. In your handout, you will see a number of the ones that I think are very ripe. There's no time right now for me to do it, but in the Q's and A's, we can talk about this eligibility age issue, benefit redesign, other changes. I did want to say one thing about the sustainable growth rate. As I testified last week in the Energy and Commerce Committee, and a couple of the members of the committee said the SGR is now on sale. What that means is that CBO, over a period of, I think, just a little more than a year, estimated that the cost of buying out the SGR, making it go away, has declined from about $300 billion to now $138 billion. It is because, in fact, the SGR overhang, it's called, is not, most of it is not from prior spending in which the cuts weren't taken. It's the projection of spending going forward for the next 10 years. There's new estimates, as I understand it, of the number of people in traditional Medicare versus those in Medicare Advantage, but in particular, the new reality that volume and intensity has flattened, perhaps more than had been anticipated. To me, $138 billion means it is on sale, and we should take the opportunity to buy it and move on. And then there's a few more, and I'm done. Thank you very much.